Hello everyone. In this video, we will continue our discussion of our DNA viruses for USMLE Step 1, Step 2 and Step 3. Once you master these DNA viruses, you will be able to confidently answer regarding DNA viruses greater than 90% of the times. If you like this content, please like, share and subscribe and follow for more. And let's pick on our discussion. We were at hepatitis B in our part A, and now in our part 2, we'll continue our discussion of hepatitis B. So, the most common hepatitis infection in the world is basically hepatitis B, right? And one very important demographic for hepatitis B, which you can find in the Vinays, is the country which is China, right? And why is USA not the one which has increased risk of hepatitis B? And the reason for this is that because more people are basically vaccinated in USA as compared to China. China has more unvaccinated people. And if they ask you what is the most common virus worldwide, that will be Hep B. And if they ask you what is the most common virus in the USA, that would be Hep C, right? And what is, of course, the mode of transmission? Of course, it can be transmitted by the IV mode, in which you have some sort of pinprick, or you're an IV drug user, or blood that is contaminated with hepatitis B, or it can also be transferred vertically from mom to baby or by sexual intercourse. So these are the four modes of transmission: mom to baby, sex, IV drug use, and blood exposure, right? And it is present in the body fluids. So if you have contact with the body fluids such as breast milk, so it's basically secreted in the breast milk as well. Okay, next on the hepatitis B immunology that we already covered in the previous video, but we'll just go through it quickly right now. We'll not do the entire table because you can watch the previous video for the entire table. HBs antigen is the hepatitis B surface antigen that shows us whether the patient is infected or not. HBs antibody tells us whether the patient is immune or not. It doesn't actually tell us whether the immunity was due to a previous vaccination or because the patient cleared out the virus previously after an infection. Then we have the HBC antibody, and that tells us that the patient currently has Hep B or he had it in the past and basically he has cleared it. So the HBC antibody develops as soon as the patient gets infected, and then we can further divide it into IgM, which tells us it's an acute infection less than 6 months, or IgG, which is going to tell us that it is a chronic infection greater than 6 months. Then there is one particular period of time which they can give you in your Vinay, in which only anti-HBC antibodies and only IgM is positive and nothing else is positive. That is known as the window period. Once a susceptible patient, he has been exposed to hepatitis B, and now the immune system is trying hard to clear it. Therefore, HBs antigen is absent along with the HBs antibodies. So body is trying hard to make the HBs antibodies, but they are not enough to be detectable yet. And then they are doubly negative. With doubly negative means that HBs antigen and antibody are both negative, and they are doubly positive. So anti-HBC along with the IgM is only positive. Therefore, in the window period, if they ask you that during the window period of this disease, which is the most reliable serological marker, then that would be the HBC antibody, because and that in that one as well IgM, because only that is present during the window period. And then if they ask you that there's a baby and he has to be vaccinated for hepatitis B, so what's the schedule going to be like? That would be at 0, 2 and 6 months, right? And it's no longer at the 4 months, right? And then suppose you have another Vinay in which the mother status is unknown, right? When the child is born. So what are you going to do, right? You are going to, and they ask you, the options are something like, are you going to give the hepatitis B vaccine or not? And whether you're going to give the IVIG for the Hep B or not, right? And then the answer would be, of course, regardless of the status, the kid is actually going to get the Hep B vaccine, but you're going to test the mommy, and if the mommy is positive, then you're going to give the IVIG, right? So IVIG is not like a given that you just have to give it regardless of the status, right? But if they say that the mommy is positive for Hep B, then of course the baby is going to get the vaccine along with the IVIG, right? And if the patient has a history of a Hep B vaccination and his titers now show that he is susceptible, then simply, of course, it means that the vaccine that the body got previously, the the resistance or the immunity is no longer present, and since the immunity is gone, you're just going to give that person a hep B vaccine again, because this happens sometimes to the people that their previous vaccine no longer it remains effective, right? And then the HB treatment vaccine, the antivirals that can be used, and entecavir along with tenofovir. And recently you should know that for hep B treatment you can also use interferon alpha. Okay, and the vaccine against hep B is basically a recombinant DNA vaccine. Of course, it's a DNA virus, right? Okay, next on, a care question can actually show you this picture in which a child has developed skin-colored or reddish papules with a central application, and they can ask you for the virus. So the virus can be a pox virus, and again, they can also ask you what is the type of virus. It's a DNA virus, and they can ask you for the viral characteristics, and you know the viral characteristics. It was the simplest viral characteristics on the right that we studied in the previous video, which was double-stranded linear, and then we said it is enveloped, and then we said it has a inner tubular nucleocapsid. So this if you have an infection by this virus, which is skin-colored or reddish papules with central ligation, and the disease diagnosis is known as molluscum contagiosum, and this is the largest of the DNA viruses, so this is known as the pox virus. And they can ask you, so what can be present in the history? This child has developed this infection, so if you ask for the history can be that the child actually went to a recent pool party, and from the pool party, by the skin contact or the water contact, the child actually developed this disease, right? And then there is another, this is one pox virus, and then there is another pox virus which is known as vaccinia, and which is similar to this smallpox, and that was used in the development of the smallpox vaccine, right? And vaccinia can show up in the on your exams as well. When they ask about like smallpox eradication, they can ask you that for the smallpox eradication, which type of virus was used. So it was basically the vaccinia virus, which is a DNA virus, just like the smallpox, just like this pox virus, which causes molluscum contagiosum, right? And this is a histopathology picture that is showing molluscum bodies or Peterson bodies that appear eosinophilic in the spinal and the basophilic layer, the granular layer of the skin. So if you were to do histopathology, you will find these molluscum bodies in the skin of this patient. Next off, we have the herpes virus families, and just to quickly revise the viral characteristics of the herpes virus family, remember these were the 6 viruses which were the 8 viruses which were enveloped, and along with the enveloped, they are the simple or the singular linear viruses, double-stranded linear viruses. They don't go on round and round like the hep B. So hep B was the double-stranded circular, but these are the double-stranded linear, and they are the enveloped, and they have an icosahedral nucleocapsid. So let's see what diseases can be caused. So we need to know what will be the vinay, and then we can tell, okay, this disease caused by this virus, right? And then we have to connect it back to the viral characteristics. And remember, of course, we are doing a discussion of the DNA viruses, so they are all DNA, right? So if a patient develops vesicular lesions of the lips and the genitalia, and they recur at various intervals, the diagnosis is herpes simplex HSV 1 and 2 infection, right? And then they can ask you that which infection is most severe. So the primary infection is most severe, and the recurrences generally are less severe, right? And this patient be preceded by the development of these vesicles it can be preceded by herpetic neuralgia. And if they ask you that where does this virus remain latent, then it remains latent in the sensory nerves, right? It makes sense that it is basically causing neuralgia and pain, so it remains latent in the sensory nerves. And then once there's primary infection, the patient can also develop fever, regional lymphadenopathy, burning, stinging, itching, and also, of course, like the pain, which is herpetic neuralgia, and the patient can also have many vesicles. And remember, the classification of the virus is double-stranded linear, enveloped with an icosahedral nucleocapsid, right? And we don't have to confuse HSV 1 and 2 by another infection which is known as chancroid. And what would be the difference? So how do we differentiate these two? In the cases of a chancroid, it would be a singular lesion and it would not be a recurrent, right? So if they give you a single genital lesion that is not recurrent, then the diagnosis would be chancroid caused by a bacterium which is Haemophilus ducrei. But if they give you clusters of painful lesions that are recurrent, then the diagnosis would be HSV1 and 2, which is a sort of a DNA virus, right? And if they ask you like about this singular lesion that is not recurrent, and they ask you what is the risk factor that can be present in the history, then you would say that it's possible that this patient went on backpacking and traveling to a third world country, because it's normally acquired overseas, right? Okay. Next off, suppose that if you have a patient who has confusion and has blood in the CSF due to temporal lobe hemorrhage, so the CSF tap that you do has lots of RBCs, then it's possible that the diagnosis is herpes encephalitis caused by HSV 1 and 2. And of course, like they can ask you about the CSF findings for this particular patients. So that what will be the arrows for glucose, protein, and lymphocytes? Of course, it's a viral infection, so lymphocytes would be high, and since it's viral, the glucose and the protein would be normal, as compared to bacterial infections. We know that in them the glucose might go down and the protein will be high, and protein can be a little bit of high in the viral infection, but the most important thing is that they have lymphocytosis, and the characteristic feature of blood in the CSF is just characteristic of herpes encephalitis. Like if you see that, you can be sure that 4 out of 5 times it is herpes encephalitis. And another clue that they can give you in the venae is that they have spikes over the temporal region, and of course that's showing that there is some sort of temporal hemorrhage that is going on. So if a patient has confusion, fever with viral CSF findings, which we just saw right now, lymphocytosis along with normal protein and glucose, and blood in the CSF, and EEG shows spikes over the temporal region, and they ask you for the treatment, so that would be intravenous acyclovir. And suppose they give you that there are vesicles on the finger in a child who touched his mother's cold store or while breastfeeding, or he was a dental worker or hygienist, and he has developed these sort of painful vesicles on the finger, then the diagnosis is herpetic whitlow, and this is basically caused by the virus HSV1 and HSV2. And there can be another patient who basically has a history of eczema, and right now he is developing these vesicles and stinging, burning pain on top of the eczema. Then the diagnosis would be eczema herpeticum, and this is basically caused by a drug. The treatment for this would be a drug known as acyclovir, and the infectious agent is HSV1 and 2. And they can also ask for the mechanism of action for this particular drug, that it is a DNA primase inhibitor or chain terminator, or like tyrosine kinase, thymidine kinase, and the mechanism for its resistance would be alteration in thymidine kinase. So it can basically cause eczema herpeticum as well, right? And they can show you this picture for eczema herpeticum and this picture for herpetic whitlow, and it's possible that they show you this particular picture in which there is a patient and he has the blurring of vision along with a dendritic T-like pattern on fluorescein installation on the eye. And it's possible that the patient also has periorbital vesicles. Then of course you're going to give him topical acyclovir. The treatment would be topical acyclovir. And the diagnosis would be herpes keratitis, which is caused by HSV1 and 2. And it's also possible that there is a patient who is immunocompromised and now he is developing pain on swallowing, odynophagia, and once you do the endoscopy you find out that this patient has punched out ulcers, right? So the punched out ulcers can tell you that this is basically herpes esophagitis caused by, of course, HSV1 and 2. But if there was odynophagia, pain with swelling, just like this in an immunocompromised patient, but now he has linear confluent ulcers, then the diagnosis will be CMV esophagitis. So always remember punched out round ulcers, right? Because just like vesicles, right? So the vesicles on the genital region or the vesicles on the finger or the vesicles in the periorbital area on top of eczema. Similarly, punched out or round ulcers are herpes ulcers, just like the vesicles, whereas CMV is basically the linear confluent ulcers. Okay. And then of course the treatment is basically acyclovir or valacyclovir, and they can ask you for the mechanism of action of the treatment, that it is DNA polymerase inhibitor, and the resistance that develops to acyclovir is caused by an alteration in viral thymidine kinase. And since this is a DNA polymerase inhibitor, they can ask you indirectly, of course, the mechanism of action, that it basically causes chain termination. So DNA polymerase basically is responsible for the continuation of the chain, so it's a chain terminator, and the mechanism of resistance is alteration in thymidine kinase. So this concludes our discussion on HSV1 and 2. Let's move on to the other herpes herpes virus in the family. The third, HHV3, is basically like the most frequent HSV1 and 2. And after that, of course, you have heard about the chicken pox and the zoster infection. So that's the third most common. So that is the HHV3, which is varicella zoster. And how will the Vinay present? Clusters of vesicles at different stages of healing in an unvaccinated child or adult. Suppose he was an immigrant and he just came to the US and now he has clusters of vesicles at different stages of healing. Then the diagnosis would be VZV, HHV3, and chickenpox. And then they can also be like another sort of an infection in which the vesicles erupt in a dermatomal distribution either on the flank or the back of the neck in a middle-aged individual or someone who is older. And it's possible that the patient had some sort of stress or a negative flux in the immunity or was immunocompromised, developed an HIV infection. So then the diagnosis would be shingles, that is again caused by VZV or HHV3. And they can ask you that what can be, like if it's a young person and he's developing shingles, so what's the next step in diagnosis? You will do basically an HIV test because this is not a disease of young people. This is basically a disease of the old and immunocompromised. So if it's a young patient is developing, it means he is probably immunocompromised and it's possible that he basically has HIV infection. Okay, and another name for shingles is herpes zoster, right? So herpes zoster is not the name of the virus. The name of virus is basically varicella zoster, but the name of the disease that is caused by varicella zoster virus is basically shingles or herpes zoster. So the diagnosis is shingles or herpes zoster, but the disease is varicella. The viral infectious agent is varicella zoster virus or HHV3, right? Okay. So once the vesicles rupture, they can sometimes look black. So that's also possible that the Vinay, they give you like some sort of eschar form, just like you can see over here, that after the rupture of the vesicles, they have actually turned black. But the characteristic like clusters of small vesicles is basically like for HSV1 or 2 or like, of course, like the VZV, once their vesicles rupture, they can look black, right? And of course, I told you that the patient can be immunocompromised or is undergoing some sort of chemotherapy and he is a kid, right? Then it's possible that the kid has developed some sort of pediatric shingles. So you just have to know that it's not just in the middle age or elder people. It's also a thing that can happen in the children who are immunocompromised, and they can show you this picture for pediatric shingles. Okay. Next off, there is another patient who is developing, of course, like the periorbital vesicles, and along with the periorbital vesicles, it's possible that he has developed a keratitis as well. So and in this keratitis, of course, like there's just the dendritic pattern. So this dendritic pattern with periorbital vesicles, keratitis, along with the fluorescein illumination of dendritic pattern, so it can be caused by both HSV1 and 2, and it can also be caused by the VZV. So in case of VZV, the diagnosis is herpes zoster ophthalmicus, but of course in the answer choices they will either give you HSV1 and 2 or they will give you VZV. They won't give both, right? So similarly, there can be another patient who is developing these like sort of vesicles that are near the ear, and similarly this patient can also have like some sort of hearing difficulty, or the patient can have Bell's palsy, cranial nerve 7 involvement, right? So if the patient has the vesicles near the ear, the diagnosis is known as herpes zoster ophthalmicus, oticus. Ophthalmicus was near the eye, and near the ear is oticus, and which is shingles of the ear. And if the Bell's palsy is caused by the VZV, this is known as the Ramsay-Hunt syndrome type 2, right? Then you must know the vaccinations that can be given. So there are basically two types of vaccination. One is the chickenpox or the varicella vaccination, right? And the other is the shingles vaccination, right? The shingles vaccination, which is basically for protecting against the shingles that develops this herpetic neuralgia, right? So the varicella zoster vaccination is basically 2 doses for the kids, and I have remembered it by a younger kid, right, who is basically a toddler, and an older kid who is now a preschooler or a kindergartner, right? So a preschooler, kindergartner is comparatively an older kid, and toddler is a younger kid. So at 2 phases of life you are going to give this vaccination. One is 12 to 15 months of age, and the other is 4 to 6 years of age. This is for the chickenpox VZV vaccination. And the single vaccine for older people is right for greater at age 50. So in your CCS cases, any person who is coming at age greater than 50 gets the shingles vaccine, or any child coming at 12 to 15, 4 to 6 gets the chickenpox vaccine. And if they ask you the type of vaccination, it's a live attenuated vaccine. Therefore, you're not going to give it to the immunocompromised. And if they ask you for the treatment, of course, acyclovir, valacyclovir, the mechanism is DNA polymerase inhibitor, causes chain termination, and the mechanism of resistance would be alteration in the thymidine kinase, and they can give you another scenario in which there's an immunocompromised or pregnant patient and he's developing pneumonia, and none of the typical pneumonia organisms are mentioned. Then you need to know peripherally that pneumonia can also be caused by varicella, right? And then suppose that you have an unvaccinated pregnant woman, and she has developed a chickenpox rash within 5 days prior to the delivery or 2 days postpartum, right? And they ask you, okay, now the neonate, what are you going to do to the neonate, right? 5 days before, so this is the delivery time, 5 days before that or 2 days after that. In that time, if the mommy develops this chickenpox rash, then you're going to give the VZV immunoglobulin. But if it is something like before the 5 days mommy developed something, or after 2 days, suppose they give you day 4, or they give you 8 days before, right? Then the baby is not going to develop, they're going to get the VZV immunoglobulin. So how you can remember is that 5 plus 2 is 7. So there is a 7 days window period, 5 days before and 2 days after, right? So in the 5 days before and the 2 days after, what you're going to do is that you are basically going to give the baby the immunoglobulin, okay? And then there can be another question in which the pregnant woman gets chickenpox, right? And they can ask you, okay, what are the particular things that you can expect that this baby is going to develop once he is born? So he can develop microcephaly and he can develop skin vesicles, demonstrating a zigzag pattern, and this disease is known as the congenital varicella syndrome. So with this, we are going to pause right now. In this particular video, we went over these DNA viruses, which we concluded with the Hep B virus. Then we discussed HSV1, 2, along with the VZV virus, and which is, so up till now we have covered up till HHV3, and in the next video we will cover up from HHV4 up until HHV8. If you like this content, please like, share, subscribe, and follow for more. And I'll see you in the next video. Happy studying.